To stabilize healthcare in Wyoming, the state must overcome a geography that leaves remote clinics and frontier hospitals physically isolated from larger medical systems. Public town halls identified the core threat to these isolated facilities. The math no longer works. Hospitals are being crushed by the high fixed costs required to keep their doors open, combined with patient volumes too low to cover those expenses. In response, the state is bypassing specialized service lines and temporary pilot programs. Instead, they are directing capital exclusively towards securing foundational emergency coverage and primary care. This pie chart illustrates the resulting $205 million budget allocation for fiscal year 2026. Nearly half of the funding flows directly to emergency medical care, with another quarter dedicated to building a clinical workforce pipeline. By funneling 3/4 of all federal dollars into emergency access and staffing, Wyoming is choosing basic healthcare survival over peripheral expansion. The largest single investment within that emergency access budget is the new Critical Access Hospital Basic, or CAHB, incentive program. This table outlines CAHB funds. Hospitals receive six-figure payouts for 24/7 emergency departments, stroke and trauma imaging, and local ambulances. But there's a strict trade-off. Facilities are financially incentivized to stop unprofitable elective procedures, entering hub-and-spoke partnerships with larger regional hospitals. Parallel initiatives support this shift by consolidating fragmented ambulance services into regionalized EMS networks and rolling out the Bear Care Public Major Medical Plan to provide affordable emergency coverage to residents. These combined policies intentionally force a contraction of services, reshaping the rural hospital business model to match actual population densities. With infrastructure stabilized, the state's second-largest allocation dedicates over a quarter of the budget to recruiting and training the people required to staff facilities. The strategy establishes new postgraduate medical education slots, while directly subsidizing tuition and training costs for physicians, registered nurses, and EMS personnel. This CMS guidance table shows the strict federal compliance mechanism attached to this education funding. Any state money used to put a student on a structured degree pathway legally binds that graduate to a 5-year rural service commitment. By enforcing this statutory mandate, Wyoming guarantees that a temporary injection of federal grant money yields a decade of predictable, local clinical staffing. The final tier of funding shifts from acute interventions to chronic disease management. The comprehensive Make Wyoming Healthy Again initiative expands local federally qualified health centers to integrate primary, behavioral, and dental care. This target metrics table outlines the state's supporting technology rollout, focusing heavily on a statewide telespecialist platform that delivers remote psychiatric consults to county jails and law enforcement agencies, alongside a centralized non-emergency transportation network. By treating chronic conditions locally and coordinating transit, these investments actively prevent Wyoming's newly stabilized emergency rooms from being overwhelmed by non-emergent patient volume. Wyoming's final implementation plan looks significantly different than its initial draft, following a mandate from CMS to completely overhaul their long-term financial strategy. Wyoming proposed locking federal dollars into a perpetuity fund for interest payouts. CMS rejected this, requiring a focus entirely on structural changes. The approved sustainability plan relies on operational corrections, enforcing CAHB right-sizing, consolidating EMS tax bases, and aligning fixed revenues strictly to fixed costs. Wyoming's rural health transformation will not survive through an endless federal endowment. It will survive because the state used this capital to permanently restructure its delivery system into a financially viable operation.